So often once we've actually got to a diagnosis with these patients, we need to actually be very careful about providing some very appropriate care following diagnosis. Appreciation that that diagnostic phase is often really lengthy and often traumatic. And those moments of relief when you're actually given a diagnosis soon fade away when you actually start to ascertain what the diagnosis actually is. So people need to be well supported and followed up very closely following their diagnosis. We need to be very careful in how we communicate the diagnosis. And an experience that I often have, because part of my role at Parkinsons Victoria is being the nurse on the end of the telephone when someone phones up and asks a question. And often my neurologist says I haven't got Parkinson's, he says I've got this MSA thing. What does that mean? Because all they've got from their neurology consult has been, you've got MSA, it's not Parkinson's disease. So that for me, the communication challenge is to actually very gently get someone to think about that it's actually not PD, it's actually an illness where the prognosis is changed. If we're involved in that diagnostic phase, we need to be very careful with patients and also be very aware that patients will actually then go out and Google what MSA is. And they will get that whole gambit of information from the internet, which will be, some will be appropriate, some will be inappropriate, some will be very, very sort of quite hardcore medical information, and may well be very confronting for someone. If someone Googles PSP on the internet, they get lots of hits about Sony PlayStation. So the internet is not such a good thing, and diagnosis by Google is never a good thing. So when we're actually communicating that information about the diagnosis, we need to follow them up. It's not just come back and see me in 3 months' time. Ideally, follow someone up within a week. And ideally, if you've got a good neurologist working for you, he may well contact you and sort of say, I've had to actually change this person's diagnosis, can you please follow them up? In regards to what their understanding is, make sure they understand it and that they feel supported, and let them know that whilst the news isn't good, we've got some very good treatments available to maintain independence for as long as you possibly can. And that if they've got questions, we've got someone who can actually answer their questions. We need to be very aware of the suicidality of the client. And a number of people who have their diagnoses shifted maybe from Parkinson's disease to these rather more life-threatening diseases, we do see a disproportionate amount of those people actually ending their life before the disease actually takes the ability away from actually to do that. And I think most of us in neurology would be aware of the patients that have suicided from time to time. We need to plan care along the continuum of the illness. And that care will often need to be collaborative, incorporating family and family needs, as well as working interdisciplinary with other healthcare professionals. We need to employ support for carers right from the start. Because as we know with neurological illness, it doesn't just affect the individual, it affects the whole family. The collaborative care between disciplines, I cannot stress enough, is so important. And certainly Jim spoke about the service at Bethlehem this morning, and that's probably one excellent example of actually the collaboration between disciplines, where no one discipline sort of works in a silo. So breaking down those silos. When you don't have special places like that and you're generally in the general healthcare system, again being aware that we can have this nice silo mentality and we do our little bit, then we hand the patient on. Sometimes we need to actually sort of cross over. Along the course of the illness, if we're therapists, if we're nurses, we're often the people who are spending long amounts of time with the patient. The patients will build trust in us. They will believe what we say. And often that puts us in a position where we might actually be having to drop into the conversation about, have you thought about the future? Have you thought about your medical treatment into the future? Sometimes medical staff will offer, oh yes, you're either NFR or you're not. We know in complex neurology, the shades of grey between the black and the white are multiple. So talking people through about what they can expect if they get sick, what we can do, and that we can actually respect their wishes is very, very important. And sometimes because it is a complex maze, that we deal with. If you've got the luxury of being able to do it, maybe sort of nominate one person within the team to actually be the contact person. So the family can pick up the phone and they've got all the contact details for whether it be Amanda, the speech pathologist, or Catherine, the social worker, that she can actually sort of take response. Okay, right, it's a problem with speech, so I'll get my speech colleague to follow you up. So a key person or a key worker to actually work with these people to help coordinate the services. And certainly in my role in the UK as a Parkinson's disease nurse specialist, you very much were that key worker, where, yes, I was a nurse by profession, but I would be the person who would be signposting people to other services, getting the referrals made, making sure that the people were seen in a timely manner, and that if that couldn't be seen straight away, we'd put something in place. I know enough about speech pathology from what I've learned over the years to maybe, okay, I can sort of talk to someone about thickening drinks or some basic secretion management to tide them over until they actually get to see the experts. And many of us, regardless of what our discipline, we do a little bit of that interdisciplinary work anyway, because we work within that area and we, by osmosis, learn from other disciplines.